Hello, good morning to everybody. Welcome to this new type of click, the Click on Air project that Marco and me want to propose to every one of you to continue our educational project and to continue to share with all of you our experience about endovascular approach, endovascular therapy of CLI. It's a big pleasure for me and an honor to be here and to have invited with us Professor Roberto Candelari from Ancona and Steven Kum from Singapore. Thank you, Roberto, and welcome. Thank you, Steven, and welcome also.
Hi, everybody. It's a very pleasure to be with you today and to look at the Marco Manzi making his procedure and to take him and help about the use of IVUS, maybe, if we should use it in the procedure. And okay, yeah, only to start now.
Yeah. Well, it seems that we are also ready for the live from Abano. So let me to call Marco. Can you hear us, Marco?
Hello, good morning to everybody. Can you hear me?
Morning.
Yeah, clearly.
Okay, good morning, Roberto. Good morning, Steven. And good morning, Mariano. And good morning to everybody. And welcome to this on-air edition, the first on-air edition of the Cli-Course. I'm very happy and I don't want to hide my emotion to share with you this new edition of the Cli-Course. So this morning we are going to share with you a live case. I hope it will be useful for everybody and significant for a formation in the treatment of diabetic patient with critical limb ischemia and lesion in the foot. I would start immediately with the presentation of the case. If it's possible to have the presentation on the screen, please, so I can introduce you our patient. The next slide, please. This is my disclosure. The next one, please. Okay. So this is the patient, is an 81 years old gentleman with diabetes, hypertension, complication with neurovasculopathy. Actually, we have a quite impaired renal function with the serum creatinine at 1.6, and there is a gangrene in the first toe with a very huge rest pain, and the TCPO2 is not so low, but is below 30. We have now 25 millimeters Ag. This patient received this morning a sciatic block under ultrasound guidance. The next slide, please. In our previous study, you can see the CO2 angiogram demonstrating a quite patent SFA axis, is severely calcified, of course. Probably there is a lesion, a plaque, an eccentric plaque in P1, between P1 and P2. And the problem is below the knee problem with an occlusion of AT and distal posterior tibial occlusion, and it's not so clear the aspect in the foot, but probably we have to try to recanalize the tibial vessel arriving in the foot. So the strategy, the next slide, please. The strategy for today is, of course, after the sciatic block, perform an antegrade ultrasound guided puncture. deploying a 6 short 11 centimeter Terumo sheet, perform again a CO2 angiography with a 2D perfusion angio final in the foot, just to have an idea of the initial perfusion, trying to discuss with you if we need to treat the lesion in between SFA and P1 I described a few moments ago. Probably if there is an indication, could be indicated to deploy an Eluvia drug-eluting stent. Try to recanalize posterior and anterior intraluminal arriving in the foot, and perform an IVUS examination just to understand the situation of the vessel, situation of the vessel wall, situation of the plaques, situation and amount of calcium in the vessel, and decide the correct size of the balloon. The next step will be the debulking with the atherectomy, rotational atherectomy device from Boston Scientific. We are going to choose the Jetstream 1.6 or 1.85 to remove the plaques, and then remodeling the vessel wall with a high pressure non-compliant balloon from Orbus Nike. The name is Jade, before the definitive treatment with drug-eluting balloons one-to-one with the vessel. And finally, we will repeat the IVUS evaluation and the CO2 angio and the 2D perfusion angio at the end to evaluate the success of the procedure. So next slide, please. I think this was the original edition scheduled for April. We are now all together. It's already a great success in my mind to have you all for this edition, heavy condition by the pandemic situation in the world, but we stay strong and we continue to try to be useful to our patients. So we can start our procedure. Everybody is ready here. We have Cesare and Enrico with me in the lab, and outside we have Paolo and all the OneView staff. So have a good day, and let's go with the first live case of Click 2020.
Okay, thank you, Marco, for all the introduction. Let me say hi to Cesare, Enrico, and all the guys in Abano Cat Lab. I miss you too much. And yeah, I completely agree with you. It's a big success for us to be here doing the Click on Air in the meantime that we were not able to continue with the original Click project, but it's just an opportunity to adapt ourselves to the new condition. I have a question for you. In the meantime, I don't want to disturb you during the procedure, but related to IVUS, first thing, I know there is a technical problem, so we will have the IVUS images. This is for the audience. We have the IVUS images, but not in a very clear situation, because the monitor of the IVUS will be the images of the monitor will be taken by a camera. However, do you believe, to be sure if the popliteal artery needs a stent or not, IVUS could be a help for us? This is also a question for you, Roberto.
I think it's very interesting to use in this case IVUS, because it's the second treatment for the patient, and we have to realize a good result for this patient. So we have many complicated situations, and I think that we will have some target lesion that we have to recognize and to treat in definitely. IVUS could be very useful for the use of uh, balloon coated balloon, and for the use of the stent to individualize the better size, the better length of the stent, if Marco should use it for this case. So I think that IVUS could give a second chance for this patient to have the better result in the use of these devices. Yes.
Okay. In the meantime, to
So
everyone who
in the meanwhile, guys, I have performed the ultrasound guided puncture of the common femoral artery, the right common femoral artery of the patient, and now we are shift the uh, the procedure under X-ray, so under fluoroscopy. We have the wire in. Is in the SFA, I think. You can see the amount of calcium is already evident. We are going to deploy the 6 French short Terumo sheet. Okay. We are going to insert 7,500 units of heparin directly into the artery. We are going to connect the port side of the sheet with the CO2 filter and the CO2 line direct to the automated angiodroid injector. And we are ready to start with the study and the CO2 angio. Okay. As you can see, we use the same procedure, the same projection, X-ray projection. We try to standardize the study. So, ready for CO2 injection? Okay. Let's go with the first run. Okay. I remember you that the patient has been positioned on the bed in the standard way. So we use to fix the foot with the support, a design angle support to help the foot to be stable, to avoid as much as possible movement.
Marco,
Yes.
can you tell us in the meantime the dose of CO2 you are injecting, the parameters?
Yes, of course. We use a standard injection from the automated angiodroid injector, and we are using now 20 ml of gas with the pressure 120 millimeters Ag. This is normally is enough to visualize all the axes. Are we ready? Let's go.
And in your experience, how frequently you're able injecting from the sheath 20 mLs of gas? How frequent are you able to study also the foot without super selective
Yes, of
injection?
course. Okay, that's the plaque. It's an eccentric plaque. And then we have a trifurcation in the below the knee.
And Marco, sorry. Marco, can you hear me?
Yes, of course.
Can I suggest you a method stick? Have you a method stick to realize where the target lesion on your CO2 angel are localized? Because it's important to make a correspondence between the angel imaging and the IVUS imaging.
Okay, thank you very
If you
much,
have,
Roberto. Mi date un ago che lo incolliamo lì dove c'è la lesione, che così quando passiamo l'IVUS abbiamo un riferimento. Thank you, Roberto.
If you have a metal stick, it's the better because you can localize the centimeters between the angel and the IVUS. But if you don't have, you can make some target as the needle to individualize the target lesion. Okay, it's correct.
Ok, we fix, però bisogna fissarlo sul ginocchio, ragazzi. Sotto,
yeah, so maybe you can use the ruler, Marco.
Non si muove.
Or if you have a centimeter, and Marco, if you have a centimeter catheter too, you can use.
Sì, metti la banda centimetrata, è un po' più giù. Enrico, è un po' più giù.
In the meantime, Marco, this lesion seems significant. What do you believe following the CO2 angiography?
Sorry?
I said that this lesion seems significant following the CO2 angio. What do you believe?
Yes, I suppose it could be significant.
And never consider the option also to do the atherectomy in that lesion, even using the small probe.
Sposterà un po' più verso l'interno. We could decide to do the atherectomy even in the debulking procedure, even in the P1 lesion. We repeat the injection just to be sure we are in the correct position. Sorry. Okay. Okay. Vai.
Okay,
Pronto? Okay, we repeat the CO2 injection. Inject. Yes, it's a couple of centimeters. Yes.
Lower of the needle, but you have the ruler, so probably you take in the ruler the blast.
Yes, it's against the proximal edge of the rotula of the patella.
Yeah.
Okay.
Just to let you know, Marco, in the meantime, Roberto Lorenzoni asked how much CO2 do you inject? It was a question that we already answered. It's 20 cc,
20 ml.
20 ml for each injection. So usually between 80 and 100 for diagnostic angio, a little bit less for the final control.
Marco, I have a question. This is Steven. Good morning to you. Very nice case and very excited. I did not know that this was the first ever click on air, but very congratulations. What is the frame rate that you are using for the CO2? Because the advantage, I think, in CLI is you reduce the contrast for important things like below the knee. But what is the X-ray frame rate that you are using to achieve such beautiful pictures?
Well, Steven, this is a very nice question because the suggestion of frame rate with CO2 was always very high, no less than 6. But we in Albano start to use it at 3 frame per second, and this is the same procedure I'm continuous doing here in Cotignola, in which we continue using 3 frames per second with very good chance to obtain, as you can see, very good result. Another interesting thing is that the Enzo machine from Abano is very new, and it is a Allura Clarity from Philips, and it has the auto pixel shift, so it helps too much to automatically correct the movement and to obtain impressive images. This is quite important, a lot of important, because I don't have it. I have the Allura machine here in Cotignola, but it's not Clarity. So without auto pixel shift, and any small movement create a lot of noise. Noise is the most frequent problem or situation with gas. It's not the quality of the images is not just related to the frame rate, but in most of the cases, it's related to the movement.
Thank you.
So you can see there is a reconstitution of the distal anterior tibial with a good landing zone in something very similar to a pedal artery, and we cannot see plantar arteries in the foot actually. And now we are going to go with the perfusion angio in the anteroposterior view, because the target of our revascularization, the clinical target of our revascularization will be the forefoot, because there is a gangrene of the first. So we must help the patient to heal the surgical wound of the amputation. So we are going to perform the anteroposterior perfusion angio. Okay, this is the proper projection. Normally we have to use contrast medium for the perfusion. I hope in the future will be possible to perform perfusion angio with CO2 too, in order to reduce one more time again the amount of contrast medium. In this case, we are going to inject 9 ml of contrast medium, Visipack 270, diluted 50%. So the pressure of injection, it's better to do with an automatic injector. In this case, it was too complex for the jungle of cables. So I will try to inject 3 ml per second. Are we ready? Okay, let's go. Okay, this is the amount of perfusion in this foot. So we can start to advance the wire, trying to recanalize our anterior tibial artery first and posterior tibial artery as a second target. And after the successful cross of the lesion, we will go with an IVUS evaluation. I would like to have a V18 wire, please. Okay, we are going with a V18 wire together with the 4 French Bernstein catheter. We will try to do the recanalization, of course, intraluminal. When we have in mind to perform an atherectomy procedure, it's quite mandatory to stay in the true lumen to avoid any dangerous perforation of the adventitia if we are subintimal. So, okay, this is the V18 wire rotated in the SFA. I try to support the wire with the 4 French Bernstein catheter. We are approaching the P1 lesion. Should be here against the proximal edge of patella. There are
Marco,
no resistance. Okay. Tell me.
In the meantime, there was a question from Agustisa, our friend from Spain. He said, what is the current weight of paralysis MEC classification? You can see it. What is the current weight of paralysis MEC classification in your decision making? Do you still try a standard arterial revascularization procedure in MEC 4 or 5 cases?
Okay, when we arrive, if we could arrive in the foot, I will try to check the outflow directly in the foot, and we will decide about the kind of patient. So, I mean, if we have a bad patient or a sad patient, this is the first attempt for debulking procedure and recanalization. So if we had a bad clinical result because of the dry gangrene, we have time to wait a little bit, and we can shift. We could shift whenever I indicated to a deep vein arterialization, of course, if we had a lack of forefoot distribution. You can see now the tip of the catheter is deformated by the calcium. I'm trying to advance very prudently with the rotation of the wire, the V18 in the middle of the calcium. In this moment, I open the projection to open the tibioperitoneal space and to have a look of the AT. But then we have to change our projection. In this lateral view, it's not easy to have a clear view of the calcium. So we have to try to interpret the behavior of the tip. You can see here the tendency of the tip to be stopped by calcium. I'm sorry, I have to advance the support catheter, but abbiamo un microcateter, eh? Okay. Okay, so now I will shift. Let me check. Maybe I'm lucky. Again, the torque, please. Let me check.
And Marco, maybe you can look at the calcium, but you can feel it by your hand, by the guide wire?
Yes, of course. There is a resistance, and when you see the tip of the wire is going to lose the angle we shaped against the calcium, we prefer to avoid a loop. We don't want to create a loop now. I want to remain as much as
Marco,
possible in the true lumen. Yes?
just a second. Right now, pass Professor Dalla Paula, Luca Dalla Paula, to see our new project and won't ask me to say hi to you.
Thank you very much. A big hug to Luca, and I'm happy he is watching us. We are honored to have his presence. So I inserted now a microcatheter. It's a Rubicon catheter 1.8 from Boston. And we try to support the V18 with this microcatheter that would have much more chances to follow. You can see how difficult is okay to arrive. Okay, torque again, please. And now we have to cross the last mile, trying to arrive in directly.
Technical question, Marco. Why 018 rather than 014 platform devices?
You know, we start always with the 1.8 just because the support is a little bit better compared to a 1.4. But of course, we have to change the wire when we arrive in the foot, and we use the 1.4 for the foot and for the jet stream, because the jet stream need a 1.4 wire. So the behavior of the tip suggests me probably we are in the true lumen. What do you think?
I think so. It
Yes.
seems that the guide wire,
Yes,
the tip of the guide wire follow the calcium.
Okay, so I'm trying to advance a little bit more the Trailblazer. No, the Rubicon catheter. Yeah. And we are going to change the wire, but first we will try to check the outflow.
Through the
resistance is very, very high. Okay, let me check the.
I did the question just to clarify to the audience and to all our friends, but honestly speaking, I agree with you. In most of the cases, we are able to arrive in the food with an 018. And personally, nowadays, I use more frequent than before 018 guide wire, because the only 014 guide wire that I have available in my cath lab today is the Choice PT. So that's the reason why I use too much 018 guide wires.
Okay, now we inject 1 ml of contrast medium just to check the outflow in the forefoot. Posso andare col contrasto? Ok. Io I think that the outflow is not bad. Augustine and all the other guys can tell us their opinion.
Their personal opinion.
Yes, of course, but I think it's not a sad patient.
I'm in accord with you. I think the outflow is present. It's not the best, but it's not the worst. So it's justified to still try to open the arteries rather than to shift suddenly for a DVI.
Yeah, I think so. But the problem will be to reopen the anterior tibial. It's very calcified.
Okay. Yes.
Marco, can I ask you to do this check with CO2 also through the Rubicon?
Yes, of course.
Catheter?
I was waiting for your. I was waiting for your suggestion. I'm ready to shift the line on the microcatheter. Okay. Okay, now we are directly connected with the. We are selective and super selective in the pedal artery. Okay. CO2, CO2. Okay. Ready? There is a still contrast medium. There was a contrast medium in the catheter. We can repeat. Now the catheter is full. You can try to reduce the. Okay.
Okay, now it's clear. Even if there was a small movement, but
yeah, there is a very fast passage. A very fast passage in the vein. So, okay, we can change the wire and put the wire for. Yes, and put the wire for a 1/4 wire for the jet stream and for the IVUS evaluation.
Marco, can you tell us something about the guide wire you are going to deploy for jet stream?
Okay, yes, because we have to use a rotational atherectomy device, of course, we have to avoid all the wire with a coverage, hydrophilic coverage, and all the wire with where there is a danger to lose the coverage and the tip. So we have to avoid long tip and hydrophilic wire. In this case, we are going to. Ragazzi, mi date la guida? Posso farvela vedere?
Yes, please.
Posso farla vedere? I'm going to show you the. Okay, let me. The wire. This is the throughway.
Okay, we can see something. The camera is not able to depict clearly the guide wire. Yeah, now
okay, you can see the tip. The tip is very, very short. Maybe on the hand is better.
It's more or less the same. When the camera is so close, the image became no clear.
Anyway, the tip is very, very short and very, very soft, and the wire is completely naked. It's a throughway by Boston. Is completely naked, so it's not hydrophilic covered, and we will avoid any danger of damage of the wire. So first of
What do
all,
you think if in the meantime you change the sheath, deploy your guide wire, and prepare everything,
yes, of
we
course.
move forward with the presentation of Steven?
Okay.
It will take no more than 10 minutes and we will be back to you. So let me give a space for the next presenter, Steven Kum from Singapore, that will talk about the double therapy, the debulking and DCB could be better than a single one.
Thank you, Mariano, and sorry to put everybody away from the live case, but it's really an exciting case, a beautiful demonstration of CO2. So my task today is to give you an idea of if atherectomy and drug-coated balloon combination may work better than just single. Next slide, please. And next slide. So we are in a Cli-C course, so we talk about the how common the FEMPOP lesion is present in the CLTI. This is a snapshot of the OLIVE registry from Japan, a well-run registry. And within a registry of real-world CLTI patients, they had almost 60% of patients with a FEMPOP lesion, as in this case. 59 or 60% of these were TAS-C and TAS-D lesion. And within the registry, 50% of these patients actually had a stent to optimize the inflow. Next slide, please. So calcium, as we always know, is probably the single most significant predictor of interventional success, underestimated by angiography and better seen on IVUS. Highly prevalent in patients with elderly diabetes and kidney failure. The mechanical effects, you get severe dissections and recoil with calcified vessels, associated with a high incidence of angiographic complications. And in the era of drug elution, it may reduce the absorption of drug. Next slide, please. So my personal FEMPOP strategy in patients in CLTI, I look at it from an acute as well as a long-term. Acute meaning 6 months, which is a reasonable time for a patient with CLTI to heal. I look at the risk of the patient. If the patient has a low risk, maybe open surgery to optimize the FEMPOP is good versus an endo. Complexity of disease, the length of the lesion, whether the lesion is a CTO, whether the lesion is calcified. And then I look at demand and supply as well. For a single small little CLTI, a little spot of gangrene, maybe the FEMPOP does not need to be as perfect as it can be. I also look at the severity of the disease below the knee. If I need to spend 80% of time in contrast below the knee, and maybe a simple stent in the FEMPOP may help me, allow me to spend more time below the knee. The risk of complications with either atherectomy devices or drug devices like embolization, and cost is a consideration as well. Long-term issues for patients with CLTI, essentially if the patient has a 1-year survival of a very low survival from CLTI, as in most of our patients, then maybe a long-term patency more than 3 years is not so important. And the other thing I look for is the ease of re-intervention. For example, if you put a stent, is the re-intervention more difficult as compared to a drug-coated balloon strategy. Next slide, please. So we all know that stents help to are essential in the area of calcium. They are prone to poor stent expansion, stent fractures, stent compression of IVUS. You can see some of our Japanese colleagues have excellent studies on this. And for those who are not familiar with what it looks like when you surgically remove a stent, this is the intense neurointimal hyperplasia that you see in either a interwoven stent or a self-expanding stent. Next slide, please. So can atherectomy alone perform well? Next slide. We do know from several references, this is a Cochrane registry as well as a study done by Dr. Katsanos that summarizes the efficacy of atherectomy, and does show that it's pretty much equivalent to a balloon angioplasty at 6 and 12 months, but there is, however, a reduction in bailout stenting, and this is a similar conclusion that Dr. Katsanos had in his review of observational as well as randomized control trials. Next slide, please. How about the DCB only strategy? How can the DCB work? When the DCB first came out, it was a question on mine. You had a drug on the balloon, and this drug not only has to transfer into the wall, but also has to reside in the wall. Next slide, please. And we all know that drug-coated balloons, you need to have a good diffusion of the drug into the wall of the vessel, even distribution of the diffusion, and long-term retention to get a durable drug effect. Next slide, please. Well, DCB works in the SFA, but we don't really understand the causes of restenosis. There hasn't really been very good analysis. This is some work done by Dr. Lawrence Garcia, but yet to be published. And we do know that after DCB, there is restenosis. Could it be due to calcium, geographic miss? Next slide, please. But of course, we have to look at this from a systematic way. Could be due to mechanical factors. After all, the drug-coated balloon is still a balloon. Maybe there's recoil intersection. Could it be the amount of drug that's going into the wall due to either calcium, plain thrombus, or could it be a technical issue of geographic miss during the application of DCB? Or could the restenosis purely be natural progression of disease? Next slide, please. Most of the studies we know in short and limited calcium in SFA are associated with some controlled studies. Next slide. And this is, however, confounded in real-world studies by very high stenting rates. So the real question you need to ask yourself is are the results due to the stent or due to the drug? Next slide, please. How about a combination of an atherectomy and drug-coated balloon? Maybe the value is in the sense of reducing the mechanical effects of recoil intersection with atherectomy in combination with improved drug uptake that could be more homogeneous and could help better retain the drug within the wall. Next slide, please. Some evidence of preclinical studies of cadaveric studies. This is an orbital atherectomy with drug-coated balloon. And for the FEMPOP, a combination of orbital atherectomy did show a better, deeper penetration of the drug, as well as a better coefficient diffusion. Next slide, please. Some meta-analysis that we have so far of the data we have with directional atherectomy with drug-coated balloon seem to have a better trend towards a higher patency, as well as a lower TLR rate and a lower bailout stent rate, but this was not statistically significant. Next slide, please. Some contemporary series we do have of long-term outcomes of atherectomy. This is a JET SCE study with a single operator, single center, which eventually showed a lower TLR rate. Some with Jetstream as well. We need a Jetstream and a DCB registry in a French. Sorry, it was a series. It was collected. It seemed to show improved patency after adjunctive DCB compared to POBA. Next slide, please. And another registry out of Korea that also seemed to show some similar benefits, significant difference in terms of patency between a DCB and a POBA arm. Next slide. Now, for those who are not familiar, the Jetstream device from Boston Scientific, it's an over-the-wire version of a rotatory debulking device. It has a fluted end that allows you to engage the lesion without pre-dilatation if it's not too tight, and allows differential cutting on the front end. At the same time, certain versions of it have a double cutter that allow more aggressive cutting with and without the blades. It also has a single aspiration and single infusion port. Next slide, please. For sizing wise, for the SFA, for me, the most common size would be a 2.4, 3.4, which essentially means that when the blades spin in one direction, you have a smaller lumen, and when the blades spin in another direction, you have a bigger lumen because the blades come out. And the minimum vessel size with the larger device that you should actually use it is only a 4.5 millimeters. Next slide, please. Just a simple case example. I'll move quickly through this. This is an in-stent restenosis at diffuse. This is a Tosaka class 2, I believe. And then with IVUS, you see a lot of material within the in-stent restenosis. Those that you can see the video within the pot at the amount of effect of the rotation is quite significant. And this device also has a wire system that allows the wire to remain in place. Next slide, please. And after a single pass, after a spider filter is implanted in the P3 area, even after a single pass, there's actually significant lumen gain with the blades down. Next slide, please. With the blades up, I'm afraid you can't hear the audio, but it almost sounds like a fruit juice machine. You're trying to core out the neointimal hyperplasia within the stent. And this is after the angiogram. You can see significant slow flow and some embolization of material. Initially, in my experience, I was very concerned about this, but it also gave me the confidence that the device was actually removing the actual material within this. Next slide, please. After drug-coated balloon angioplasty, you're able to see significant lumen gain on both an angiogram as well as on IVUS. Next slide, please. So when will it not be appropriate? In my practice, next slide, certainly for a subintimal recanalization, it would be, in a sense, potentially dangerous for causing a rupture. And for patients with CLTI, I routinely use a filter. Next slide, please. So in summary, if you put all the concerns about FEMPOP lesions in CLTI, be it the ability to address recoil intersection, urinary hyperplasia, speed of intervention, you do see that atherectomy combination with drug-coated balloon will give you a drug-eluting stent-like result without actually the scaffold. Next slide, please. So again, a combination of atherectomy and thrombectomy to address the mixed lesions within a complex SFA lesion, having aspiration, having a fluted tip to engage the lesion, differential cutting with or without the blades, different sizing as well, really gives you the opportunity to treat a complex patient. Next slide, please. Thank you very much for your attention.
Okay, thank you, Steven. Thank you very much for your presentation. That was perfect just to introduce what is Marco going to do. So I have a very fast question for you. In the meanwhile, I will open the question center to check if there is any other question. Do you believe, or in your experience, how important is to have IVUS for pre and post atherectomy use, atherectomy therapy?
So in my mind, the IVUS would be used if you for two essential reasons. Number one, if you think that you're subintimal and you want to verify that you're in a true lumen, from a safety point of view, I think the IVUS is absolutely essential to help you. With regards to using the device, the IVUS can also help you to size the catheter, to give you an idea of the size of the catheter, to help you choose the catheter a little bit better. And last but not least, we do know that there is a limit to what the angiogram can tell you. In terms of visualization of the dissection and recoil, and the IVUS can tell you that if this patient would benefit from a stent, perhaps even after atherectomy, there are cases where you get a suboptimal FEMPOP result that eventually does need a stent. So I think the importance of the inflow in FEMPOP cannot be fully emphasized. That we cannot, for real CLI with a large wound, we cannot leave the cath lab with a significant SFA or popliteal inflow lesion. So in my mind, those would be the usual things that come that will allow me to use an IVUS.
Okay, thank you so much. Well, to be back to Marco, that seems quite ready with IVUS and probably also with the jet stream. Marco?
Okay, Mariano. In the meanwhile, Steven was given the presentation, and we changed the sheet from 6 to 7 to prepare the approach with the atherectomy device, and we performed the IVUS evaluation, and we are ready to comment the imaging together with Roberto Candelari. We performed the IVUS both in P1, SFA P1, and in the anterior tibial. We used the 1-4 probe, but the 1-4 probe was not able to cross the occlusion completely, so we have the imaging only at the middle third of the anterior tibial artery. The occlusion is very, very difficult to be crossed with the IVUS, despite the low profile and the capability, the crossability and pushability of the device. So we are ready to comment. Can we see the IVUS with the camera? Yes. Potete inquadrare l'IVUS, per favore?
Well, I think that in the artery we'll have the calcium just all around the lumen, and the lumen will be very tight.
Noi non lo vediamo.
It's arriving. It's arriving, Marco. The guys are changing for the camera. In the meantime, we are sure. So we were not able to cross the 80, but for sure we will have a good opportunity
la
to
telecamera
assess
con quella
lesion in
là,
the popliteal
inquadrare
artery.
questo. Con questa inquadrare questo. Perché non si vede che prima si vedeva? Sorry, we have to shift with the camera.
Yeah, I know.
Okay, but we can comment just now.
Okay.
That
Okay.
tibia.
Okay. Now this is the popliteal tract and SFA where we had the plaque. So can we see the imaging running? Okay, this is the IVUS acquisition, and you will see now the lesion.
Okay, so it is easy to recognize the calcium lesion just around, and the more bigger calcium lesion at 6. So I think that the lumen is not so tight. You can pass through by your catheter, and you okay. In this case, we don't have the angio, the imaging with the angio to recognize the segment in which we are.
It's difficult to, but we are 2 centimeters below the needle.
Okay.
Exactly.
Should be the target lesion. You could have the canalization, your main recanalization.
Yeah, the main question is, do we have to scaffold this kind of lesion? Do we have to try to debulk this kind of lesion? It's an eccentric plaque, and below the eccentric plaque, there is a strange flap. I don't know if you can see now the progression here. There is a lesion, a strict lesion. So in my mind, I would go with probably just to start with a high pressure balloon, 6 millimeter, and then we could decide if we need to scaffold. My impression is that probably there is a complex lesion. I don't know, Roberto, because this imaging is is quite new for me.
It's a good imaging. It's a good imaging, and I think that you have to scaffold the lesion because you have to make space between the round calcification and the flap. In effect, is there, and you have to treat. But I don't know if the high pressure balloon could be the best solution for this. Maybe if you have a landing zone for stenting, you could think about to put a stent in this after, not not using a big pressure balloon.
Si può stoppare su questa lesione qua, guarda. Vai avanti, ancora. Qua. This is the worst lesion, I think, in this, because there is something. I don't know if it's a piece of a plaque, if it's something like a flap, but in this area the lumen is really reduced. Is much more worse than the angio imaging, I think. So yes. And can we see the imaging of the tibial artery so we can start with the atherectomy in the tibial, because we have to recanalize the tibial. You can see this is the anterior.
Yeah, and I imagine that the IVUS was like this because you have more difficult to pass through the lesion or the anterior tibial. So it's regular, and in this case, you could use I think a scoring balloon, maybe, if you have a scoring balloon to reduce the calcium plaque.
Okay, we try to cross the lesion with the jet stream 1.6. Dai, let's go.
Okay, the jet stream, but I don't know how much the jet stream could be useful in the plaque lesion with the calcium. So I think that maybe in this scoring, I would use a scoring balloon in this case in my lab. But you can use the jet stream too.
We don't have a scoring balloon now. We don't have a scoring balloon for below the knee in this lab, so we schedule to try to debulk with the rotational atherectomy device. So this is a 1.6 probe.
Marco,
tell me, Mariano.
When you use IVUS, you have to spend time to use it, but it's very useful in case because you can appreciate how much you can open the lumen and get more around the calcium plaque just around, and to have more space.
Bye.
Clear. Again, technical question. Steven showed just a few minutes ago very nice cases with Zestream. One of those with the result of embolization, but fortunately he was working with the filter. How you comment that? Because I really understand you cannot put a filter in the dorsalis pedis, and so which is your feeling about the possibility or the opportunity of this embolization? Personally, I hope nothing will happen, but we want to know your perspective.
To Steven?
Yeah. Also, question to me?
Or both. I was asking to Marco because he's going to perform the atherectomy. Okay, Steven, give us your opinion because Marco is so concentrated.
Yeah, I think in this case, I must quantify that my experience with below the knee atherectomy or jet stream or otherwise is not extensive. I must say that in this case where there's a very tight lesion, maybe the stenotic lesion itself would act as a natural filter to prevent distal embolization. I think the main things to worry about are to keep it very nice and slow. And hopefully with the aspiration potential of this device, we're able to remove the plaque and to change the compliance of the vessel to allow better balloon angioplasty without dissection or recoil. So sometimes it's actually pretty unpredictable. So in a patient with a desert foot, for example, I certainly would be very cautious about atherectomy. But in this case, I think it's a reasonable option to try and change the plaque morphology and maybe improve balloon angioplasty and allow better drug absorption. But again, for below the knee orbital or rotational atherectomy, in combination with drug-coated balloon, there is actually no very strong evidence to suggest that.
Okay, thank you, Steven. Do you have any comment from the CAD lab, Marco? How it's going?
Can you hear the noise?
Yeah.
There is a reduction of the of the engine power.
So Marco, how fast do you advance the catheter? Is it based on the look, feel, and listen? You hear the sound and have to look at the catheter?
Yes, I'm trying to push the catheter very, very slowly. But when the tip is arriving against the occlusion, you can see and hear the variation in the rounds.
Marco, in most of your practice, do you require any pre-dilatation, or does the catheter engage quite easily most of the time?
Yes, could be a suggestion.
But you did some pre-dilatation right now, or the catheter engaged the artery till this point for itself?
Relax. Okay, now we remove the probe and we go with a pre-dilatation balloon. Mi date per favore per predilatare un 1,5 2 o un 2 Jade per favore? Sì. Vai. Ok. Vai.
Marco, did you perform some atherectomy also in the popliteal artery, or you leave it?
Pardon?
Did you perform the atherectomy also in the popliteal artery, or you leave it?
No. I think in the popliteal artery for today I will go with a high pressure balloon, and then I will scaffold with an alluvial stent. I think because is the lumen is quite tight, but not so tight for a rotational atherectomy. So I don't know if we could remove the plaque with the rotational atherectomy. I will try to crack the calcium plaque with a high pressure non-compliant balloon, and then probably I will decide to scaffold with the drug-eluting stent. Now I'm going to pre-dilate a little bit the anterior tibial artery with a high pressure non-compliant balloon from Orbus Nike. Is a Jade balloon, is a 2 millimetri.
And Marco, after you should.
See. Now we are going with a 1.580 balloon, and then we shift to a 2 millimeter 180, and we try to predilate a little bit this AT because seems to be very, very hostile to be crossed. Okay, this is the Orbus Nike Jade balloon. It's going to cross. Let's go as distal as possible. Okay, bye.
Can you tell us something about the Jade balloon? This is over the wire. This is a monorail balloon.
Yes, the Jade balloon is a rapid exchange system balloon with a very low profile, available from 1.5 to 5 millimeter size. Hai gonfiato? Sgonfia. Now we inflated at 20 atmospheres. We can reach 26 atmosphere. The profile is very, very low. Yes, inflate. is very, very low, and the balloon are very, very resistant to the calcium and very efficient to crack the calcium plaque sometimes. Okay, date il 2. Now we try to.
Marco, you probably agree with me. I think when we started doing high pressure balloon angioplasty as well as yourself, in combination with some nerve anesthesia, I think we were able to be more aggressive with balloon angioplasty to get lumen gains. So I think the combination of nerve anesthesia, which is very safe, will allow us to do what we need to do to get lumen gain below the knee.
Yeah, I personally fully agree, but I'm specifically in that case so curious because the balloon transition was before the pre-dilatation was more or less the same than the atherectomy. So it means that the lesion was very, very challenging, and the atherectomy device arrived close to the ankle and was not able to progress, and it was the same with the balloon before the pre-dilatation. So very nice activity of the debulking device. Very nice pushability and crossability power.
Yeah.
Could I just ask a question, Marco, with regards to the popliteal lesion? One of the things that I looked at on the IVUS is that it really looks like a very complex, eccentric, almost coral reef-like lesion. Would you consider a primary stenting maneuver where you put the stent and then you do the post-dilatation instead of a high pressure first followed by stenting? Could you consider that?
If you suspect that it's an open plaque, so with no cap, and so we could have the possibility to have an embolization, probably your strategy has to be followed. So
I must say, looking at the angiogram, it looked okay, but after the IVUS, it looked a bit worrying.
Yeah. Yes, the IVUS imaging was impressive. The plaque is really more complex than I could imagine. Now we have another jade. This is 2 millimeter, and it is 180 in length. Okay. We are now at 18 and 20 atmospheres.
Mm-hmm.
Okay. And okay, deflate. Again. $20. Okay. Okay, we remove the balloon, deflate.
So it was a pre-dilatation very fast. That's correct?
Just a pre-dilatation. Yes, it's not a definitive dilatation. So we just want to crack a little bit and let the atherectomy device arrive down. I would like to show you the acute aspect with CO2. Possiamo fare una...
Okay, Marco, if you agree, we will see the control and we will move forward with Roberto presentation about IVUS, and we will be back finally to see the last passages of the case.
CO2? Yes, okay. Okay.
Let's see the control, please, Sebastiano. Can we be back to the live case, please?
Perfetto, vai con live, con il jet stream, per favore. Yes, the artery seems to be open now. There is a little bit of flow. Now we try to remove something more with jet stream.
Well, yes, you still have the guide wire in, so for sure there is much more flow inside this vessel. I think it's a nice job till this point. If you agree, let's continue with Roberto's presentation about IVUS, and in 10 minutes we will be back to you. Thank you.
Okay.
Please, Roberto.
Thank you, Mariano. And it's a pleasure to be here with you. And I think that I have to speak about IVUS role in recanalization, but in this case, it could be very interesting to look at the recanalization by Marco, looking with IVUS what the result about the anterior tibia. But maybe we can look at the procedure, at the result just after. So next, intravascular ultrasound has emerged as a dynamic imaging modality that provides real-time visualization for catheter-based interventions. Next, nowadays, digital angiography is still considered to be the gold standard for defining peripheral arterial anatomy, and so useful to technical advances in endovascular therapy. Despite providing an accurate roadmap and planar representation of the vessel lumen, angiography provides very little information about vessel wall or plaque lining the vessel. Furthermore, angiography provides only limited information for the interaction of endovascular devices with the arterial wall. And while angiography is necessary for vessel navigation and treating specific anatomic regions. Next. Intravascular ultrasound integrates angiography by yielding cross-sectional imaging with improved resolution. Typical measurements obtained with IVUS include luminal diameters, luminal cross-sectional area, vessel wall diameters, vessel wall area, plaque shape, plaque length, plaque volume, plaque composition, and overall plaque burden, which have all been evaluated with pathologic confirmation by many papers. Especially from coronary. No, next, please. Typical foremost IVUS. No, next. Just back. Okay, thank you very much. Foremost IVUS is an adjunct for determining the adequacy of endovascular interventions, and when treating endovascular failures, the operator can determine the presence of thrombus, intimal disruption, dissection, ulceration. The system offers virtual histology tool, and it's a software that characterizes plaque morphology. The software relies on IVUS images created by the intensity and the frequency of returning signal that vary depending on the type of tissue surrounding the catheter. The representative image have been validated in pathologic specimens of coronary arteries, naturally, in order to delineate plaque characteristics into 4 categories: fibrous, fibrofatty, necrotic lipid, and calcific. Following the advances in endovascular tools, IVUS has provided a wealth in vivo information that has furthered the development of medical therapy, debulking devices, angioplasty, balloon, and stents. Next, next, yes. And more, you can use less contrast media and less radiation exposure using this device. Next, low frequency catheter are utilized for aortic and venous imaging, but the higher frequency catheter offer detailed imaging solution needed for smaller vessel, like in a lower limb. Catheters are deployed over the wire, which eliminates artifacts seconded to the wire. So the 0.018 catheter is a classic over the wire instead of the 0.14 that is a rapid exchange catheter. The catheters are based on a solid-state design and rely on a miniaturized phase array elements oriented circumferentially at the tip of the catheter. The element receive backscattered ultrasound and the signal are routed to a computer which constitutes real-time images. The advantage of a multi-element catheter include no movable parts, no required rotation to acquire image of the vessel, and over the wire configuration. The system also offers color flow with both the catheters, 0.018 and 0.014. Unlike ultrasound, transcutaneous duplex ultrasound, color flow does not detect velocity shift, but the software release relies on changes in a single image from one frame to the next frame, typically 30 frames a second. And the change detected is respectively frame is represented in red, and in areas of stenosis, the color changes to orange. When you perform this procedure, the transducer has to be perpendicular to the vessel wall, and typical images are obtained when performing manual pullback, and the catheter is more likely to the center of the room. Next, please. The treatment of PAD is just now heterogeneous as the disease process. Treatment option include angioplasty, atherectomy, stent grafts, drug-coated balloon, drug-eluting stents, and limitations of angiographic evaluation may account for the widely disparate result of treatment of PAD. It's clear that IVUS provides the interventional with additional information about and beyond that of angiography, which should translate to the better results, so it can assist you to take decisions during your interventional procedures. IVUS has provided a tool for evaluating the mechanism of your procedure. How much calcium hold on tight lumen, what's the shrinkage of the plaque, any dissection, and more. It can input the size, the caliper, the length of your device. The ability to assess stent expansion and stent apposition could be extremely challenging when utilizing angiography alone. Several studies documented an unexpectedly high, 80% stents were incompletely expanded, incompletely opposed, and asymmetrically expanded. Next. The disassociation of angiographic findings and histologic analysis has been documented in both coronary and peripheral vascular territories. And comparing the maximal diameter stenosis from angiography to the maximal area stenosis from IVUS, angiography consistently underestimates the degree of stenosis of 10%. Qualitative variables assessed by angiography are replaced with an objective IVUS measurement. For instance, when determining the over length of plaque stenosis, angiography underestimates the length of stenosis as much as 5 millimeters. Similarly, plaque concentricity is severely underestimated by angiography. The degree of plaque asymmetry within the vessel is one of the most appreciated factors in the context of treating vascular disease with interventional devices. The shape of the plaque can be fully appreciated, even with biplanar angiography of the disease segment. One of the main advantages of IVUS is the ability to objectively assess plaque morphology. And this has several implications for the treatment of peripheral vascular disease. Qualitative assessment of the echogenicity alone can be inaccurate due to the similarity of the echogenicity between different tissue composition, thrombus, lipids, fibrous material, calcium. So we have the virtual histology that can analyze the raw radiofrequency data obtained and develop spectral profile for different tissue types. So you can have fibrous, fibrofatty, necrotic lipid, calcific. All these features can allow you to decide which device is better between those that you have in your storage room, naturally, called problem. So the question, and the next, please. The question, the challenge for the interventionalist is what is the optimal diagnostic modality to analyze target vessel? Which is the optimal recanalization modality? How to maintain the lumen? Next. In this case, we have a short obstruction of SFA that we treated the target lesion with a balloon angioplasty. Next. So at the end of the procedure, next, the lumen gained good, but following IVUS check showed an intimal flap. Next, only after knowing it with IVUS, we also managed to demonstrate it, the flap, with other angio projection, so to have a good representation. Yeah. In this CT imaging case, the severity of calcium was particularly challenging for the recanalization. Next, the angiogram, okay, revealed only the lumen defects in the target areas. Next, instead of IVUS that show not only the tight lumen, but the circumferential position of the calcium too. In this case, we used the shockwave catheter, that is an intravascular sonic waves cracking calcium device. And next, we achieved a good angio result. Okay, next. Verified with IVUS, where you can see not only a larger lumen, but the calcification more rounded on the border. The increased value of the lumen area is well showed by the IVUS, and in this case is a good result from the pre and post intervention. In this case, the angio shows severe obstruction or SFA with a poor foot flow. Next, after many balloon angioplasty, we had a poor result, so we decide to release a mimetic stent for the arterial segment. Next, and in this case, IVUS was essential to prepare the lumen of the vessel, especially when we use mimetic stent. Next, and this is the confirmation by the chroma key IVUS, the stent right position, and the vessel patency. So next, at the end, IVUS plays an important role in the examination of in vivo peripheral vascular disease, improving the technical success of all endovascular procedures. The technology has provided an examination of the plaque distribution, vessel remodeling, and the response to the interventional treatment. In addition, IVUS serves as technical adjunct for endovascular procedures that has demonstrated superior outcome compared to angiography alone. Okay, it's the end. Thank you.
Well, thank you so much, Roberto. It was an incredible presentation and very nice cases that following the flow of your presentation, finally I said, okay, means that we cannot continue working without IVUS. It's more or less like CO2.
Yes, in fact, we when you look at the IVUS images, you have another word. It's your mind open in another world, and all the area that you can recognize, but the section, the flap that you cannot look at the angio just after your procedure. And maybe it's challenging our way to work. In fact, when we use IVUS, we are used to perform more stents, because maybe there are many the section, many flap, many possibility that the flow doesn't gain well, and so we are used to put a lot more stents than before with the angio alone.
Okay. In the meantime, there is a question before to go to the Marco. The question is from Michele Antonello, a big friend of us from Padua. He asked, your suggestion is to use IVUS in all cases or in selective situations? If so, can you tell us which are your indications? The use of IVUS had a significant impact in your practice in terms of changing interpretive strategy and in the result. Well, for sure, you answered the second part of the question. It's change your practice because, as you said, as you explained, you are prone to deploy more stents than without IVUS. But do you believe that is the future we need to use it for all the cases or just in selective cases?
Is the future, because you need a trial to understand what are you looking at by IVUS. And after you maybe the use will get you to take many others devices that at first with the angel only you couldn't use. So I think that for the using, I would say is now we have not the correlation between the angel target angel target with the IVUS correspondence. So it's important now to put a meta stick to have the correspondence between, and not to have the length of all the SFA or the completer, but to individuate the target lesion by angel and to make IVUS in the target lesion to have the correspondence and the look at the image of the lumen and of the dissection of that you can have of the calcium distribution. Like in this case in which is operating Marco in popliteal, maybe okay, we have just a localized site of calcium that could be difficult for expanding the stent. Also, if it's correct, maybe to put the primary stenting in that segment, but I think that we'll have problem to expand the stent just after the position of the stent because we have a very big calcium in the part. So okay. maybe could change our way of operation. If I could make a directional atherectomy, just to get off the calcium and then to put the stent.
Maybe. Okay, clear. Let's be back to the cath lab. Marco, can you hear us?
Yes, of course. So guys, in the meanwhile, I have dilated the anterior tibial artery. Lascia stare il piede, Enrico, grazie. With a 3 millimeter jade high pressure 26 in the distal part, and after the IVUS measurement, we decided to dilate the proximal mid part of anterior with a 3.5 balloon. So despite the initial aspect, the real size of the vessel was bigger, and we could use a 3 millimeter up to the ankle and a 3.5 in the top. Posso avere una CO2? I can show you the acute result after the angioplasty with the high pressure non-compliant, and after the debulking of the tract included between 25 and 30 with the jet stream. Okay, let's go.
Yeah, it's arriving.
Sorry, he moved. Possiamo rifarla, per favore?
However, we were able to see the gas passing till the ankle. There is some noise related to the movement, and I believe you still have the guide wire in, but for sure now the vessel has flow.
We dilated at 3.5 in the top. And then I arrived with the wire in the ankle in the posterior tibial.
There is a question from Roberto Lorenzoni about your recanalization of PT. He asked, which guide wire are you using for that?
In the posterior?
Yeah. I think it is a V18 like before.
Yes, it was a V8. No, sorry, the patient is vomiting now, so he's moving completely everything.
The nice thing of the live. Do you have any image of IVUS to show us after pre-dilatation and final dilatation of AT?
Yes, we can do the IVUS now. Possiamo passare l'IVUS adesso dopo la dilatazione, per favore? Allora, intanto gli faccio... Metti contrasto! Ok.
So iodinated contrast median angio. Yeah, you cover it.
Com'è la pressione? È bassa. We have the pressure is a 95 on 70.
That's the reason why the flow is so slow. But the vessel is patent, and I think you obtain a very nice result, very nice remodelation of the AT, not only related to the balloon angioplasty, but also related to the atherectomy in the proximal part. Do you agree?
Yes, of course. Yes, it seems to be a good result. If we now we can see the IVUS aspect.
Okay. And a question for Marco. Marco, can you hear me?
Yes, of course.
Okay. What's your feeling with the tip-loaded guide wire in a calcified tibial artery like this? Would you use this kind of guide wire?
Our strategy is always step by step and wire escalation. So we start with a normal hydrophilic wire like a V18 or V14 or Pilot or PT2, and if we fail in crossing the calcified lesion, we can shift to tip-loaded wire, so we can use a CTO wires like an Astato 20 or Cook 25 CTO wires, or Victory, but always step by step. And when you are sure you are in the true lumen. So now the IVUS is in the ankle. If you remember, we could not cross the lesion before. We are ready to start with the evaluation. Vado? Ok.
Pull back.
Can you show us the camera with the camera?
Potete inquadrare l'IVUS, spegnete le luci.
Perfect, we can see it.
Seems to be a quite acceptable lumen gain.
Because you have a rounded calcium border that is impossible with only the angioplasty to treat.
Yeah, I think it's an acceptable result. The lumen gain is for sure acceptable compared to the previous IVUS that was unable to cross the AT. There are some arterial wall defect and too much calcium for sure. But
yeah, but it's impossible to eliminate the calcium. So maybe in this case could be a better result with the shock wave, maybe. to disrupt
yes,
the
a nice option too. Okay,
I think, maybe if I just made a comment, Marco, I think that's a nice picture of concentric lumen gain with the atherectomy combination. So the question is, perhaps even without any part modification, you could have a significant dissection or recoil even with a standard high pressure balloon angioplasty. So I do believe that what you're seeing is a disruption of the concentric ring of calcium that jails the expansion that allows, that's probably the main cause of, or one of the causes of tibial vessel occlusions when they're long lesions. So, but very nice result you have there of the tibial vessel.
Yeah, I fully agree with you, Steven. The most important thing is to broken the ring calcified ring of the tibial wall, and it seems that finally Marco achieved that result. What about the popliteal artery, Marco? Or you still want to concentrate in posterior tibia?
So now the strategy is to complete the AT with the Ranger balloon 1-to-1, so 3.5 in the top and 3 millimeter up to the ankle level.
Mm-hmm.
We are going to use a 4 millimeter balloon in the top because 3.5 we don't have. We will inflate a little bit less. And in the meanwhile, I think we are going.
11 minutes.
We have 10 minutes.
Yeah, the last 10-15 minutes.
Okay, 10 minutes. We can do. Mi dai un'eluvia? Che misura aveva qui nella poplitea, per favore? Allora mi dai un'eluvia 6?
talking about 6 millimeters.
For the eluvia stand, for the
mi dai un 6 mm, mi dai un'eluvia 6, il più corto che hai? 70, 6,70 e un Dorado o un Mustang di analoga misura.
But Marco, choose the right size. You should use IVUS imaging.
Yes, we did, and they collect. Okay. They already collect the size.
Perfect.
Actually, Roberto, I think based on the IVUS that
Marco
did, I do believe the
P2,
P3 was about 5 millimeters in diameter, just by visual estimation. So perhaps the 6 millimeter stent would be reasonable, at least in the distal popliteal or
Posso andare? CO2? Vado?
Yeah, I fully agree with you, Steven. I think 6 millimeters is a reasonable diameter for the popliteal artery, and this was the
actually. I do have an idea, because based on the IVUS, the disease seems to be more significant than the very short lesion. The whole vessel is calcified. So, just wondering, perhaps the IVUS could help us mark where the most severe portion is, so we get total lesion coverage with the drug-eluting stent. But I must say, I'm worried that if we see more, we treat more, and then we might end up stenting the whole vessel. But I don't have the magic answer. But maybe Roberto, you have an opinion on this?
So we must focalize to see what we want to see, to avoid to see too much.
But it's correct. If you see more, you want to do more. I think it's very.
Yes, it's true.
It's true.
Okay, now we are going to follow Steven's suggestion, and we deploy.
So primary stenting.
Yeah, we will deploy the Eluvia stent first.
Marco, this is a 6 centimeter stent. Is that right?
It's a 6 millimeter.
For length?
60.
70.
60.
And now we postulate.
Okay.
Marco, do you have a double wire in the SFA?
Yes. I have a 1/4 and 1/8. Because the 1/8 is in the posterior and 1/4 is in the anterior.
So the
Okay, now
stent
we are
goes
going with
into
the balloon.
both wires? Or?
Yeah, I think it's
The
not.
stent is free around.
Okay.
Yeah, the stent is 35 platform and Marco have an 18 or 14.
Yes, we could insert both wires in the stent, in the stent shaft.
Because you have no problem because the stent is 0.035, so you can
Yes,
use.
of course. 1/8 and 1/4 is 30. No, 20.
Yeah.
This moment, mathematics is not my. Okay, we are arriving with the balloon. This is a Mustang balloon. So the stent is 60. Okay.
How much pressure?
We are going step by step. So nominal pressure first. So mi dai la nominale a 6.
Okay.
Okay, nominal 10.
Is the stent well open?
We have 10 now.
Mm-hmm.
And we can increase the pressure up to 20. Okay, we are going.
Mariano, are you also using
12
non-compliant balloons in your practice, Mariano?
Yeah, I really believe in the use of no compliant, high pressure, ultra non-compliant balloons to treat specifically this type of heavy calcified lesions.
It's a very low compliant balloon, the Mustang. It's not exactly non-compliant, but it's a very few compliant. Now we are 21 atmospheres. Okay, stay like this, 1 minute.
Without the risk to damage the artery.
Amazing, the patient has no pain because of the nerve anesthesia. I think this is very comfortable for the patient. No tachycardic response, no adrenergic response.
Yeah, exactly.
But also, if there's a perforation, you don't see it.
Yeah, that's true.
But
maybe not good to say that.
Perform a sciatic block. We perform a sciatic block, but below the knee. Okay. So with the popliteal access, not higher.
Clear. So could feel pain at that point also. How long do you think to maintain the balloon inflated, Marco?
1 minute and we check. Okay. Let me see.
And look.
There is the print. Pronti con CO2. Vai. Much
Well,
better,
for
huh?
sure, much better than before. Exactly, much better.
Okay. Can we check with IVUS the apposition?
Perfect. So there's several papers on the use of IVUS post-stenting that show that if you have a minimal luminant area of more than 15.5 square millimeters, it is perhaps associated with a better patency at 6 months. This is a Japanese study. So 15.5 by METS becomes a 5 millimeter lumen. And Mariano, you would know from your experience with the Supera that actually the Supera also, the data seems to suggest that if you implant a 5 millimeter Supera, the patency is much better than maybe a 4.5 or 4. So maybe 5 is the magic number based on IVUS and the studies that we see so far.
Good. Yeah, when we started to use Supera, the first cases we did with the 4.5 in the distal popliteal artery, we finally realized the stent was so small. We called the patient back, a number of patients back to perform an angio-CT. We realized that was the reason why we have been using the 5.5 in most of them, and now with the 5, probably as you said, it's the magic number.
Sì. Vai.
Okay.
Ok, posto fuori. Basta. Sì.
What do you think, Roberto?
Okay, it's a good position. I would question to Marco if he has the chroma key in the software for the software IVUS.
Abbiamo il chroma flow, sì. Per fare il chroma flow devo ripassare?
No, it's correct, but you look at the little stenosis just in front of the patella, and I think that the IVUS. Okay.
Ok. Sì, pull.
Look again.
Ok, stop. Okay, can we have a CO2 on the foot and perfusion? Because we have only 10 minutes, I would like to, yes, the acute result. Then we continue with the drug-eluting balloon. But let me check first the acute result in the foot. Siamo pronti con la CO2? Vado? CO2? Okay.
Well, very nice. Fast flow, good outflow, good wash out of the gas. So maybe from here that the image is not so clear. Maybe you have some residual stenosis at the ankle level, but I'm not sure. Let's see the reconstruction.
Ok, prendi questa. Perfusion. Mettimi quell'altra che la faccio uguale. Ok. È uguale, vero? Così. Ok. Posso andare? Ok, prova a fare un confronto.
Well, personally believe, Marco, that in this type of very challenged case with heavy calcified lesions, you did a fantastic job, and the result is clear and evident because now you have direct blood flow in the anterior, and for sure you also improve the inflow through the popliteal artery.
Okay, you can see here the graphic, the comparison between the purple curve and the white curve. The purple one is before the procedure, and the white one is after the procedure. So we had an acceleration in the arrival of contrast medium in the foot. So we have arrival, the time of arrival, and the density of contrast medium. The time is quicker, is faster. We have at least 3 seconds faster, and the density of contrast medium is higher. So with just the anterior tibial artery recanalized at ankle level, we had an improvement in the situation. We will complete the procedure with the Ranger balloon drug-eluting deployment in anterior tibial, and I will try to complete the recanalization of the posterior, arriving, I hope, in a lateral plantar artery to improve much more the flow in the forefoot for this patient, because this patient is scheduled for a first toe amputation in the next day. So we will try to do our best.
Okay. In the meantime, Marco, as always, thank you so much. It was, I personally believe, a very nice case, very didactical case in which you were able to show us the crossing, the therapy, and IVUS. And it was also very nice to have Steven and Roberto commenting the IVUS images, the therapeutical strategies, and thank you to all of you for your suggestion and for your collaboration in this first session of our new Click on Air project. So thank you so much. I don't know, Marco, if you want to say something.
No, thank you to everybody for this wonderful cooperation. I think the interactivity is could be achieved with a little bit more difficulties compared to a live event, but I think we could have a nice discussion, focus on the technical aspect of the procedures, and alternatives suggestion, like Steven suggested us to perform a primary stenting and a post dilatation in my mind, it was a great suggestion, so we could avoid a potential embolization. So thank you, Steven, and thank you to everybody for joining us this morning.
Okay.
I try to complete the procedure now.
Yeah, we know that. Let me close the first session saying also thank you so much to all the participants, to all the audience. Thank you to Boston Scientific and Philips to support us. I can see Michele Sedran in the cath lab, so thank you to everyone. Thank you to OneView for support us with the transmission, and thank you to Mariana Menegon and to Imiti for the organization. So thank you so much to everyone, and see you in a couple of hours in the second session between 4 and 6 p.m. Italian time. Thank you. Bye-bye.
Bye.
Bye.
Bye, Marco.
Hi, Steven.
Hi,
Bye.
Steven. Ciao, Roberto. Ciao, Mariano.
Ciao.
Ciao.
Bye-bye.